So now we're going to hear a little bit about SNF. And the SNF world is a mystery to many, but it is so important in the lifespan of our patients and the continuum of care, and is becoming more and more important as we have aging baby boomer population, et cetera. So we have Meryl Manning here. She's a nurse. She's a post-acute care manager with Prestige, and she's going to give you an overview. Well, she's been with Prestige, and her clinical background is in acute care hospitals, and then she's been in the transitional care field for about 5 years. So she's going to give you a little overview of SNFs and some of the challenges there. We mentioned before Meryl arrived, I was saying how there's so much misunderstanding about SNFs, and I remember, and I mentioned that I worked with some hospitalists one time who thought every SNF had a pharmacy. So what was the problem when your patient arrives there and you don't have meds ready for them? So just understanding a bit of what those barriers are. And then I think she's also going to mention that we're just beginning to work with CareOregon and Prestige and with a pilot with OHSU to see how we can better partner up to make it these transitions more seamless and just work better for our patients as well as all of us, our partners in the healthcare. So.
Hello, I'm Meryl Manning. As Jane said, I work with Prestige Care. I'm an RN by background, and I did start out in the acute care setting. And I've also done roles, a little bit of working in people's homes, did kind of UR, a little bit, the one who is seeking authorization for patients, doing kind of the chart review piece of it. I have not been a floor nurse at a SNF, but I've filled in as an SDC, which does like teaching and training and education. And it was a very sharp learning curve for me coming from, and so I have a little bit of a perspective of knowing I had my own misconceptions about SNF and what it was and what it wasn't and why and how annoying it is and all of these things, right? So I'm coming from a little bit of that same perspective. But what I'd like to do today is just sort of give a general overview. What are some of the things that we deal with at that level of care? Why do we maybe respond in the ways that we do? And then just be open to answering some questions for you guys if you have real specific cases you want to run by or anything like that. So an average SNF, even within Prestige, that varies quite a bit. Company to company it'll vary. But in general, there's about 140, I think, in Oregon now. Roughly usually about 60 to 70 patients or beds. They can be upwards of 120. The real little ones are more like 40. Staffing. Nurses. CNAs are set by the state, as you can see there, and it's a set ratio. And so can be tricky if any of you have ever dealt with staffing ratios, though. You know that once you've tipped over that magic number, you have to either implement another staff or kind of shift around your numbers. So that can be a little bit tricky. Nurses, on the other hand, there is no regulation for what it needs to be other than 8 hours of RN coverage within that 24-hour period. So you can't have back-to-back-to-back LPNs for a 24-hour period, but that is the reality of it, guys. So what does this mean? Let's break it down. A SNF of 75 patients, day shift. So charge nurses on the floor in the hospital, those are the people who are kind of overseeing everyone. Not the case. We call our just on the floor working staff nurses, hands-on patient care nurses. Those are your charge nurses. So if you ever hear that reference, that's what a skilled nursing is referencing for you. You have 4 of those. 3 on evening shift, and then about 2. And that can flex a little bit. It's like anything, we all deal with FTEs and HPPDs, and so you have some buildings that have gotten a little more creative with their staffing, and they've worked it to where they have one nurse doing admits, or they can play with their numbers a little bit, but you have what you have as far as dollars and positions. So think about, for any of you who are nurses in the room, think about caring for 18 patients. And do we know the kind of patients that we're sending to sniff these days? We are taking TPN, trachs, wound vacs, patients who have complex psychosocial needs, addictions needs. And we also have the patients with dementia, wandering, we're kind of doing the whole gamut. Yes?
I just have a question about the role division between an RN and an LPN. Are there certain role distinctions, or do they do the same job responsibilities?
The same job responsibilities. Yep. And then also, while we're taking care of that acuity of patient, without the support of RT, IV, we don't have in-house lab, we don't have in-house pharmacy, all of these things, that very same nurse who has 18 patients also is probably responsible for taking an admit and discharging people all at the same time. So I think we know that there are some processes we could do better with. For instance, when we're discharging someone, doing that full medication reconciliation, doing a little bit more patient teaching and training. But the real question is, and I think this has been a common theme, right, of, what was it, the cliche for a village? Who said? But I think it's good to understand what that nurse is up against in that 8 or 12-hour shift, and why it can be a little sparse on some of the ideal practice that we'd like to see. They just literally don't have the capacity or time. I'm going to tell you a story about a patient who we were admitting from one of the large hospital systems here in Portland. She was on TPN and coming to one of our skilled nursing buildings, Prestige here in town. And I fortunately was working with the building to do some teaching and training around TPN. And so I was helping them bring the patient in on the shift. And as I'm getting the orders from the hospital, I'm like, well, where are the TPN orders? It said patient on TPN at this rate, run 16 hours a day. And I was like, okay, that's great, but where's our order? Where's the real order for TPN? So I called care manager. Well, I sent you the order. Here, I'll send it again. She sends me the exact same thing. So unfortunately, I think sometimes care managers may or may not, we can't be all familiar with every aspect of healthcare, but I don't think that particular nurse was familiar with TPN and what we need to see and what a pharmacist needs to see in order to compound that very specific formula. So spending time on the phone trying to say, okay, where's the order? Where's the order? Well, finally I figure out that the inpatient pharmacy had communicated with the long-term care pharmacy, sent the order directly to them. So the building did actually receive TPN, but as nurses, we still didn't have the order, and our job as a nurse is to compare the order with the bag and figure it out. Okay, so great. We figured out where the order was. I call the pharmacy, they fax it to the facility. But then I'm reading the discharge summary, and it's talking about lipids and how there had been a mix-up on the weekends. This patient's BMI was greater than optimal, and so she was only on the lipids, the fats, every 3 days a week. But in the hospital, that schedule had gotten mixed up, so it was on hold for a couple of days. Well, day of discharge, they forgot to order lipids on the order form that they sent over to pharmacy. So then I'm calling both pharmacies saying, how do we get around, and did I mention no inpatient pharmacy? So what happens with TPN when someone comes to sniff, you'll get usually at least 3 days. It's a lot like home infusion. So we already had 3 days worth of a specific prescription sitting in our fridge at the sniff. So now it's like, oh gosh, are we gonna have to waste this because we don't have the lipids? So finally get a hold of someone who says, oh, well, here's what happened. We forgot to order the lipids. We'll rewrite the order for you. But then they couldn't actually give an order to say, yes, this patient can go without lipids for 3 days, or we need to restart them, or when to restart them. So who do we need to call next? Then we're trying to get a hold of the doctor who wrote the orders inpatient. You get the drift, right? So that took me at least an hour, hour and a half of just, that was my only focus and dedicated thing to be doing at that moment. And that resource is usually not available. That's usually that nurse who has 18 or 25 patients trying to figure out this whole mess of what to do. Who else is in the building? So Monday through Friday, we've got the director of nursing, resident care managers. Those are all typically, the DNS is always an RN. RCMs are almost always RNs, but sometimes those positions, especially in smaller communities, are being filled by LPNs. And then they get like signed off on certain things by an RN. Those like more nurse manager roles play into the overall nursing bucket of staffing, just to keep in mind. So that's kind of partly why you see the hands-on level of nursing care be a little look short, is these guys technically play into that number. And then you have Monday through Friday, and this is why, honestly, you guys, when we do talk about weekend discharges, and boy, if we could get that sniff off on the weekend, who the heck is going to receive that patient? Because we are running, you literally have in the building, you don't have any of these folks. So you have a nurse with 18 patients and aides, the CNAs, like you saw the ratio, and that's it. So that's why for us it's a little bit, I mean, weekend discharges can be a little bit of a problem, honestly, because without these support people, we're very bare bones. And then therapy is a huge help to us, and it really can vary how often they're in. It just depends on the caseload at the time, how many people need which services. So what's the deal with our coverage, MD coverage in SNF? There you have it. Let's go back to the example of a facility with 75 patients. We, for the most part, the facility MD will cover about 75% of patients. That has turned into, it's almost preferable at this point, just because the coordination that it takes to truly be working with someone's community PCP or a doctor makes it, excuse me, it can be very difficult to coordinate what we actually need with 24/7 coverage, phone calls, faxing with a good response time. It's almost better, honestly, to have the facility MD covering, because we have a direct line of communication to them. You know, we're all accustomed to one another. So check out some of the actual. So I'm gonna get to this and talk about our regulation, but per regulation, the amount of time that a patient needs to be seen by an actual provider or physician is very, very little. And some of the issue is these rules and regulations are from the 80s, and they haven't changed much. And the landscape of skilled nursing has changed hugely in that time, hugely. So when it was really more of your long-term folks there to live who are decently stable, makes sense. People at home don't see a doctor, you know, every day or every week even, right? But that is not what we're dealing with. And so part of where we've had to shift our resources and why we're still kind of in a buckle with our profit margin is we have increased the level of provider rounding just because it's necessary at this point. Our people are sick and we need that support. The patients need that support. So you will see that for the most part, I think facilities are starting to get coverage at least by like a mid-level practitioner Monday through Friday-ish. And then we, of course, have them by phone call and fax on off hours. But it's definitely not as robust as you might imagine transferring from the hospital, and why it's really, really important to have thorough and anticipatory orders. Because someone may not be seen by a physician the day of, the day after, or even the day following that by a real hands-on live provider. Yep. So let's talk about these federal regulations. If anyone's curious, you can go to cms.gov. And you can search and read out the actual law of the land for skilled nursing and why we do some of the things we do. But I want to break this down for you a little bit. So resident rights. Have you guys heard a sniff or anyone quote that to you? Okay, what does that really mean? It gets very detailed if you get into the real document of it all. But they have the right to do many, many things, including come and go as they please, have visitors come and go as they please, refuse meds and treatments. And then a real key point I want to point out. So this whole question around SNFs not wanting to accept patients who are experiencing certain challenges with houselessness or drug addictions and trying to figure out their treatment therapy. So we are required per regulation to have a safe discharge plan. So what does that mean? What is a safe discharge plan? Well, we have our own idea of what that means, and as medical professionals, we try and have certain things in place. But per the regulation, and how it boils down is that if a patient and or their family don't feel safe with where we are sending them, they have recourse to call an ombudsman. They can turn us in, and then there's an APS investigation, and we get fines. We get into legal processes where we have patients have, even if they were short-term, long-term, they have 180 days, that's 6 whole months. Even if they were agreeable, like, yeah, you know what, I like my tent and I want to go back there, and they don't have any medical needs, say, okay, we'll set you up to go back to what you consider your home. 3 months down the road, it's getting cold, and they say, this isn't safe for me, I don't like this, I can't get what I need. We get in trouble for not providing a safe discharge plan for that person. It's the truth, yep. So it's very, very difficult for us to work with, and why we have to be extremely careful with who we bring in, because once we have them, they really are our responsibility for quite a lengthy amount of time. And as you can see, that becomes problematic when you look into the other regulations, which it really is true. We are extremely regulated. And as I mentioned before, orders are really key to skilled nursing. We are completely driven by orders. Even things that you would think are nursing judgment, or you name it, even if it's like over-the-counter cough drops, those sort of things, we have to have an order for it. So what I want to point out is, have you guys heard of the survey, right? And the Medicare ratings, the star ratings? So we get those star ratings based on this annual survey process where a team comes in unannounced. They can come in 24 hours a day. They come in on the weekends, and it's like, surprise. And they walk in, and they don't talk to anybody other than residents. So they ask their opinion on everything up, down, and sideways. And if someone is reporting a complaint, they kind of start digging into that complaint. And some of the IJ, which means immediate jeopardy. So when I thought, oh my gosh, that place must be a disaster. They've got these immediate jeopardy fines, like they can't accept patients. They must have people falling out of bed, half dead, right? No, so you can receive an immediate jeopardy tag. You have the resident who, we have very strict rules around smoking per the fire marshal. It's not our choice. If you have that person who brings in a lighter and cigarettes into their room and sneaks it in without our knowledge, and then surveyors come in and find that in their room, that's an immediate jeopardy tag. And we get daily fines, and we can be told that we are putting the entire building at risk and that we must stop admitting. Yes?
Do you restrict patients, or do you not accept patients who are smoking? Or
Our company does not. We just try to explain to them ahead of time so they know the expectation around that there are supervised smoking times, that sort of thing. If 2 residents have a physical altercation between one another, we get in trouble for that. If there's a threat of psychological harm versus, if it was a threat of real physical harm, that's also considered just as serious in an immediate jeopardy situation to a resident, patient. Get this one. Okay, so falls and elopement. Patients, residents have the right to fall. So that's why we can't do restraints. We don't do bed rails. SNF has this whole thing around it. However, if we have a fall with a substantial injury, we can also then get cited and tagged for that injury. Kind of a pickle. I don't know what we do in that situation. Same thing with elopement. If we have a person who's an elopement risk, we're required to do all this documentation, do visual checks, but if they exit the building in between checks, we get an immediate jeopardy tag for not caring for them appropriately. And then meds at the bedside is huge, you guys. Like I mentioned, cough drops, nose spray, eye drops. If grandma has a cough and grandson brings her in some cough drops and then survey walks in and those are at the bedside, we get tagged with immediate jeopardy. So talking about skilled nursing, and I'm probably running over, aren't I?
We'll be fine.
Okay, so what are some ways that we can all, when we look at working better together, looking at ways that we end up having frustrations with one another in the community? First thing, with follow-up appointments. So we do send folks out to their follow-up appointments or appointments with specialists while they're with us. But technically, so the first one, I'll say in order here. So the AVS, we get random after visit summary. So often what we will get is actually what's handed to an individual when like you and I walk into the doctor and we see our doctor and they hand us a document that's written in patient-friendly terms and it says, here's what happened at your appointment today. It might give some recommendations, but we can't do anything with that information at skilled nursing unless we have physician orders from the appointment. So if they're recommending a brace or they're recommending someone do, follow up with another provider or, maybe change something with their medications, we can't do that unless it's actually been a written order. So there's a lot of miscommunication about what we actually need from the office when they're coming back to our care. Another big issue is sometimes someone had a hip fracture, they go in and see the surgeon and the surgeon's like, you're all healed up, you're good to go, you can go home. So then either they physically go home and we're like, where did they go? We don't know where they are. That doesn't mean they're discharged from our care. And we have the same process just like inpatient. We are technically an inpatient level of care. So we have to have a physician who signs off. Therapy has to say they're ready. Nursing has to say they're ready. We have to give them, all the proper documents. So making sure we're in really good communication with one another and understanding that any medications that do need to be ordered or changed at the appointment have to be ordered through us, not their own outpatient pharmacy, because we run into an issue with insurance and billing, but around medications, depending on what the person's payment is when they are in the facility, they get a whole 30 days billed and delivered to us at the skilled nursing facility, and then it's this whole process of either giving them those leftover medications or not, and it's different per patient. But I guess just realizing that if a prescription is filled outpatient by their family, that inhibits our ability. We can't fill and bill for that because it's already been filled and billed, right? And then just making sure, I think someone mentioned earlier, but making sure that we have, before we offer something, we've actually cleared it, that their insurance is going to cover whatever we're offering them, right? So opportunities for collaboration, and Liz is going to come up and really delve into, I've heard pre-manage come up today a little bit. So there's all these touch points where I have seen, I came into the field of transitional care 5.5 years ago, and that's before the penalizations were happening. That's before you saw all these wonderful positions of transitional care pharmacists and nurse and all of these programs where people were in the community. So I've seen a lot of change and so much progress, and that's really exciting, right? But I think the point that we are at now is, I'm pretty sure most of you in this room, if you're working in transitional care or not, recognize that we all have our own programs going on and none of us are working very well together. I feel like I'm often stepping on people's toes or duplicating work, and I've had this real frustration of like, what do I do about this? Like I can't, I spend half my time calling 5 different transitional care people to figure out who's taking over the lead on this or whatnot. So at all of these touch points, I think we have some opportunities for working closer together. And I think my answer to one, playing the same game. So we don't want someone playing Monopoly and someone playing Uno. That's not going to work. So we all, first of all, need to be playing the same game. But then we have to be on the same set of rules. And my real hope is that with pre-manage, as Liz explains to you, that is going to start giving all of us the quick information we need so we quit spinning our wheels in that limited time we have just trying to figure out who's on first, who all is trying to help this person and not duplicating those efforts. And I think Jane mentioned, but just I'll kind of reiterate that the pilot that we're starting to look at with CareOregon Prestige OHSU is looking at the hospital workflow, like how can we actually start communicating better with each other from the very start when someone hits the door. And then we're also going to work on a secondary piece of like, okay, once they're at SNF, we can do this better, because I'll be the first to say we are not very good at inviting people in and inviting people in at the right time to participate in someone's care. That being said, SNF is kind of this black hole care level, because most services and programs that I see out there are designed to leave them alone while they're at SNF. And I think that is not very effective. And so I would encourage everyone to start thinking about opening programs up and opening up your services to people while they are in SNF. In particular, that mental health, substance, like they get this real intensive treatment while they're in the hospital. They have people meeting with them every day and peers, and I'm seeing it improve. But then it used to be they'd totally stop. There'd be no support at all while they were in the SNF, and then supposedly magically they're supposed to pick back up with all of these great, touch points. So that'd be my advocacy is let's start bringing your supports into SNF. We'll start trying to work more closely with you and span that gap. I think that's it.
Thank you, Meryl.
Thank you.
And any questions, if you can just hold those until after Liz is done. One of the things, that was a really good point about how things just disappear, vaporize while they're in the SNF. And we need to make this continuum really strong and this partnership strong. And I think one of the things that Liz will talk about is we're very excited to start onboarding SNF reporting into pre-manage, and Prestige is one of the first groups that's going there, and we're working to help them get in there. And so for primary care, for instance, what a treat it will be for you to be able to see every day when you see who's gone inpatient, who's in the ED, who's discharging. Ooh, they're in the SNF. And then you know where your patient is, and you can be communicating and helping coordinate. So I think that's going to be pretty cool.